Indian Arthroplasty Association webinar on a very interesting topic, that is the total knee arthroplasty in valgus knee. And valgus knee, as we all know, is more difficult to treat. One, because it is a difficult situation. Usually the deformities are extra-articular also. And another reason that we in India are not having enough number of patients of genu valgum, apart from some patients of rheumatoid arthritis and some cases of primary osteoarthritis. So we'll be discussing in this webinar various very interesting tricks of how to treat it in a safe and reasonable way, and how to make your decision. So I'm sure that this will be very useful discussion, especially for our younger colleagues who are starting the arthroplasty in difficult situations. We have very good faculty, which I will request Dr. Uttam Garg to give the detail after the address of Dr. Ram Chadha. Dr. Ram is the incoming president of Indian Orthopedic Association. Thank you, Dr. Ram, for joining us. Thank you so much. And we'll request you now to say a few words and then start the webinar. Thank you so much.
Good evening, everybody. On behalf of the Indian Orthopedic Association and on behalf of the president of the IOA, Dr. Atul Srivastav, I welcome you all. It's indeed a coincidence that I have been here for both your webinars, the first one as well as the second. And I am actually a spine surgeon now by choice, and I would have been an arthroplasty surgeon, as I mentioned last time. It's just that destiny led me elsewhere. And as I said, I can make unhappy people less unhappy doing spine surgery, unlike you guys who can make very unhappy people very happy. So I'm so happy that you guys are all together. And you're talking about the valgus knee. For me, in my training days, the valgus knee was only rheumatoid arthritis. We didn't know of anything else. And we looked at it as the rare situation, uncommon, because most of the times we saw these short-statured women coming into our OPDs, obese with bilateral genu varum, and very rarely do we see anything in valgus. So I appreciate the effort you're putting in education and training, and it's a joint venture of the Indian Arthroplasty Association and the IOA, and I welcome you all. I appreciate the efforts put in by the Arthroplasty chair of the IOA, which is Dr. Rajiv Sharma, as well as the support coming in from the IAA leadership, which includes Dr. Ronan Roy and Dr. Rajkumar Nateshan. And we have Dr. Uttam Garg, who's here as the webinar convener today. You have an excellent faculty, and I know most of them. There are very dear friends of mine who are all here, and I appreciate that all of you are putting in your time, despite the fact that there's a very interesting cricket match that's going to happen very shortly. So all the best. Have a great time, and let's educate each other. Thank you very much for having me. God bless you.
Thank you, Dr. Ram. Thank you so much for your good words. Yeah.
Thank you, Dr. Chadha. So can I share my screen for just introduction?
Yeah, sure, Uttam. Make it fast and crisp.
Yeah. Is it visible now?
Yes,
we can say.
Yeah. So myself, Uttam Garg from Lucknow, and I will be the coordinator this webinar. So
Uttam, bring it to slideshow, please.
Make it full screen, please. Uttam.
Yeah.
It's fine.
Yeah, it's okay.
Yeah. So we have our faculty or Dr. Jean Brad, but unfortunately he is not with us due to his personal reason. So we will be missing in this webinar. Another faculty we have Dr. Rajiv Sharma. He's the chairman of Mulchand Medicity, and he's an arthroplasty chairman of Indian Arthroplasty Association, as well as in arthroplasty in IOA. Another faculty we have Dr. Manoj Vadwa. He's a Light Orthopedic Institute chairman in Paras Hospital. Recently recognized by World Bank, a World Book of Record by performing 3,878 joint placement in a year. So very good. Congratulations, sir.
Thank you.
Another faculty we have Dr. Dhansekhan Raja. He's a consultant joint replacement surgeon from Ganga Hospital, Coimbatore. He has a many fellowship awards within Australia as well in Singapore. Another faculty, we have Dr. Abhay Alens from Jodhpur, AIIMS, Rajasthan. He is a well-known figure in adult reconstruction arthroplasty fellow in Germany. Another speakers we have in the case presenter, Dr. Mindal from Delhi, from Amrita Institute of Medicity, Faridabad, sorry. Another faculty we have Dr. Nirmal Jadodia from the Durgapur, West Bengal. He's also done his Ranawat Fellowship. Other faculty we have Dr. Rajiv Verma from Manipal Hospital, New Delhi. We have discussion panelist of Dr. Mohanty from Mumbai, Dr. Rakesh Rajput from Kolkata, Dr. Vijay Kumar from New Delhi, Dr. Subhas from Delhi, Dr. Avtar Singh Kamboj from Amritsar, Dr. Sanjeev Gupta from Jammu, and Dr. Anil Vora from New Delhi. So all of the faculty, most welcome, sir. See you in this further discussion. Right, sir? So I request now further for my first speaker, Dr. Abhay Alens.
Sir, you will have to unshare your screen.
Yeah, I am doing. Now, Dr. Abhay Alens, I'm just inviting you for the classification of valgus knee and its implications.
So can you see my screen, sir?
Yes, sir, we can see.
Okay. 1 second.
Yes, can see.
All right. So good evening and thank you so much, Dr. Rajiv and the Indian Orthopedic Association for the invite. My brief today is to speak on the valgus knee, the classifications, and what clinical relevance we have from being able to classify these knees. So essentially, the tibiofemoral angle of more than 10 degrees qualifies as a valgus. About 10% of the total knees that we do will be valgus. So it's not a very common entity when it compares to the quantum of total knees that we do. And overall world literature essentially speaks of 3 basic common reasons why the valgus knee is more difficult than the varus one. One, because the surgeons are less familiar, and there's a paucity of soft tissue laterally as compared to that medially. The second is the higher risk of common peroneal nerve palsies, especially the ones with the flexion valgus. There are osseous defects in the lateral femoral condyle, as well as in the posterolateral femur and the tibia. And an increased Q angle essentially manifests as an external rotation deformity of the distal femur and proximal tibia, and sometimes because of chronic remodeling changes, which also causes trochlear erosions and lateral subluxations of the patella. So the anatomy of the soft tissue that has gone haywire essentially means that there is a tightness of the lateral soft tissue sleeve and an attenuation and a laxity of the medial soft tissue sleeve. And essentially what we are looking at in balancing is that the lateral collateral ligament and the popliteus will be tight in flexion and extension. The IT band and the posterolateral capsules will be tight only in extension, and the popliteofibular ligament is tight only in flexion. So depending upon the kind of deformity we have, one has to look at basically releasing or stretching out these particular ligaments. On the osseous side, essentially there is an asymmetric wear and hypoplasia of the posterior condyle of the femur, as well as the posterolateral condyle of the femur and the tibia. There may be erosion of the trochlear groove and an asymmetric wear causing maltracking of the patella. And there'll be external tibial torsion and increased tightness of the lateral retinaculum, which is enhanced and exaggerated by the chronic valgus remodeling of the distal femur and the tibia, and even in extra-articular deformities. The pathoanatomy essentially is complicated more by the presence of sagittal plane deformities, which means that there could be a valgus, a flexion valgus, or a hyperextension valgus. And sometimes these multiplanar deformities have problems associated in the foot, wherein there will be hindfoot deformities with or without subtalar subluxation, as well as distortion of the midfoot complex. And basically what this does to a valgus corrected knee is that post-total knee arthroplasty, sometimes these patients with foot deformities will have residual lateralization of the mechanical axis more than where it belongs. And then there will be metaphyseal valgus remodeling of the femur and tibia because of the chronicity of the problem. So if one comes to classify the valgus knees, essentially Ranawat classifies them based on three important things. First is based on the degree of deformity, the status of the medial collateral ligament, and the amount of lateral release that is required. So the type 1 is a minimal deformity where there would be a minimal stretching of the medial soft tissue sleeve. Type 2 has a substantial deformity of more than 10 degrees and less than 20 degrees. These are knees which are associated with bone loss and with stretching and attenuation of the medial collateral ligament. And type 3s are the ones where there is a severe deformity. There will be associated osseous deficiency and an incompetent or a partially competent medial collateral ligament. Mulaji and Shetty, our own Dr. Mulaji, has modified this classification, and now they have described 6 types, basically on the severity and the correctability of valgus, association of sagittal planes and extra-articular deformities, and the status of the medial collateral ligament. So a type 1, according to Dr. Mulaji and Dr. Shetty, is a correctable valgus where there is no associated deformity and there would be a medial collateral ligament which is functioning fully well. A type 2 is a rigid valgus with no associated deformity with a medial collateral ligament which is intact. Type 3 and type 4 have the association of sagittal plane deformities, where type 3 is associated with a hyperextension deformity and type 4 is associated with a flexion deformity. Type 5 is where the deformity is so severe, the valgus is so severe, and it is associated with incompetence of the medial collateral ligament, and which is where we start thinking and talking about building in constraint into a total knee arthroplasty implant. And type 6 is a valgus with an extra-articular deformity. And what an extra-articular deformity does is that it exaggerates the Q angle and it causes a secondary contracture of the lateral retinaculum and the lateral soft tissue sleeve. So here's a 55-year-old lady who has a correctable valgus on the left side, on both sides. This lady went in for a standard total knee arthroplasty and with standard releases which were very minimal. And we were able to get a very good, a balanced total knee onto this lady. Type 2s where you would have a rigid valgus, and these are patients essentially where you would require an anteromedial approach. You would require to factor in the valgus correction angle, and Dr. Mulaji has published on this, that there is an inverse association of the valgus correction angle with the severity of the valgus and in the knee. And one would need to reduce the marginal osteophytes. The PCL may or may not be reduced. If you have a stable balanced PCL, it is not a must to remove. And the posterolateral capsule or the posterior capsule would need some release or some bifrusting to get in a balanced extension gap on which to build a flexion gap. So this patient had a CR knee and eventually did very well. Type 3 knees are those where one builds in a sagittal plane deformity along with a coronal plane deformity. And this was a patient who had a valgus hyperextension knee, wherein we went in and had to build in a constraint into her total knee implant. And she required her PCL as well to be taken off, obviously, if you're going to be using a constraint in this case. The next type of valgus is a flexion valgus. These are the most common types. These are the ones which are most commonly associated with the common peroneal nerve injury. And this is where one would really need to balance out the extension space and then make it rectangular before one can balance the flexion space to the extension space. So this patient had the standard anteromedial approach, had the valgus correction angle factored into the distal femur jig, had the releases, the standard releases, and in addition to those, we needed an IT band bifrusting and a PS implant and got a stable, well-balanced knee. The type 5 valguses are the severe ones, and this one had a bilateral hip along with all the changes and a very stiff and rigid valgus on both the flexion valgus on both the sides with very minimal range of motion. This patient had undergone a bilateral total hip arthroplasty 3 to 6 weeks earlier, and then we were able to do, we had to do a constrained total knee arthroplasty for him. What we also needed to do was to do a prophylactic fixation with a DFLP just to prevent an interprosthetic fracture because there was a very narrow zone of transition between the Wagner stem and the stem of the total knee implant. And then you would have the type 6 extra-articular deformities, wherein there is a secondary additional contracture of the lateral sleeve and the lateral peroneal retinaculum, and which would require an appropriate implant, and these do extremely well. So the valgus total knee, essentially the implant choice will vary from the degree of valgus and the degree of instability or instability of the medial collateral ligament. The soft tissue releases is a plethora. It is a complex thing. Everybody has their own go-to method or manual. But by and large, what works mostly, and one has seen what has been advocated by Elkus and Ranawat, is the inside-out technique, which has shown 100% survivorship at 10 years and 83% survivorship at 15 years. And this means balance the extension space after the distal femur and the proximal tibial cut, remove marginal osteophytes, release PCL, do the posterior capsule and posterolateral capsule release. If it is further tight and extension, balance it further with IT band pipe crusting to maintain continuity of the IT band. Popliteus may or may not require to be released. And once the extension space is rectangular, then balance the flexion space and take your posterior condyle femur cut and have a nice balanced total knee arthroplasty. Thank you for your time.
Thank you, Abhay. I think it's a very interesting explanation of the classification of various very difficult types. Uttam, I think we can take up the discussion after the 4 talks.
Okay, fine. No problem, sir.
To save the time. Can you invite the next speaker, please?
Okay. So next speaker, Dr. Nirmal, are you ready?
Dr. Dhanshekar Raja.
Raja, sorry. Dr. Dhanshekar Raja. Are you ready, sir?
I'm ready. I'm ready. Just.
Yeah, he will talk on the balancing of the TKR by the parapatellar approach, lateral parapatellar approach. Is it?
Just a second. I'll share my screen.
Next, we will have Dr. Manoj.
Dana, is it okay? We take up Dr. Manoj's talk and then after your talk?
Just a second, because I need to. I'm traveling on the way to Coimbatore.
Right.
Okay.
Sure.
To finish and then continue my travel.
Okay, fine.
Sorry for the delay. Suddenly, I'm not able to share my screen. I checked it before.
Yeah. Yeah, can you switch off your video and then try? Maybe the connection will be better.
Okay.
What is the problem? Is there internet problem?
No, suddenly it's not coming up. Maybe you start the next lecture.
I think so. We invite Dr. Manoj Wadhwa to speak on his soft tissue release in difficult valgus knee. Manoj, can you please share your slides?
My screen is also not coming. Is something wrong? This
This is like,
yeah.
Somebody has sabotage.
no, I think this may be because we are also live streaming on Ortho TV and IOA TV also. Maybe some soft issue glitch in this. Manu, you're not able to take up your screen?
Story is coming in my share screen.
Nirmal, can you unshare your screen? I think that may be the reason.
No, I can get in there. Yeah, I can get it now.
Yeah,
Can you see my screen, Rajiv?
we can see now.
Yeah.
So I shall be speaking about soft tissue corrections in a valgus knee. The first thing to start from is the basic point to understand. A valgus is not a mirror image of a varus knee, and there are certain protocols. Very, very simple. There's some background with a lot of disturbance. So you have to first analyze whether the bone loss is there or the soft tissue deformity is there. Majority of these cases have this kind of planovalgoid foots. So the footed ankle guys would say, see these a lot and the kind of implant they're going to use through. So we have to first see if it is a stiff valgus or it is a flexible correctable valgus, because that dictates a lot whether you teach with the bone loss is an issue or a soft tissue is an issue. Once you do an exposure, which is the midline, you have a choice of going in the lateral parapatellar, which Janashikar will show it to you. I will be focusing on the medial parapatellar, which is my workhorse. The only cases where I take a lateral parapatellar is where I have a sublux dislocated patella. Otherwise, majority of these knees I handle through the valgus approach only. So the certain, I think, carry-home messages for young arthroplasty surgeons. You should always medialize your intermedullary rods for a non-robotic or a non-navigated surgery. I always keep a 3 degrees of valgus because I do not want to end up with a hypocorrection of my deformity. So whenever you cut this, you will have a differential cut. You will have a far lesser lateral condyle because you have a hypoplastic distal as well as posterior lateral condyle of femur. So your tibial alignment goes the same way with the medial to mid-third of the tibial tuberosity. Be very particular about your tibial cut and rotation. So slope is an important part. I am a CR surgeon, and for all these deformities, I normally do a CR knee. All of these knees which are tight in valgus, you have to do a pie crusting of the capsule as well as the IT band. Never cut the popliteus or the LCL. Rotation, a very important part. Just do not take the posterior condylar axis as a benchmark. Here you have to see about the tibial rotation, the white sides lines, and mainly the transepicondylar axis. Your tibial cut and transepicondylar lines have to be in the paraloid. So once you make these cuts, you size up your tibia, you see your tracking. So normally for majority of the grade 1, 10 degree, 20, this kind of deformity, you just pie crusting helps you out with a very stable knee with rectangular flexion extension gaps. Check your stability in mid flexion, full flexion, and extension. And going on to the patella tracking also. This is full seating of the patella lying into the sulcus, full bending. And for majority of these valgoid knees, this situation works. You might have situations where you have very tight lateral structures, pie crusting of IT band and posterior capsule. Use a laminar spreader, identify the tight bands. Still, you will find many times that you have a medial laxity. So tightening of MCL is the tougher part. So the better part is go back in and do release with 11 gauge needle, your posterior capsule and the IT band tightness. Once you do these structures, you will have a rectangular flexion gap, well-balanced knee flexion and extension. A third case where you have these valgus with FFD. So these are the stiff knees, which are a bit of a tougher situation. You have planovalgoid foots, and in these cases, if you see the kind of deformities are grotesque. They would around 40 degrees of a valgus deformity. FFD gets lot corrected with anesthesia, but if you see the deformity, it's huge. There is also stretching of the MCL. So here I do a very selective medial release just up to the mid-cornal plane. Don't go to the posterolateral corner or posteromedial corner. Do a selective medial release, sublux the patella, take out the osteophytes, and decompression of the posterolateral gutter is extremely important. Take off all these osteophytes and all bony pressures that are there. The same rules. Medialize intramedullary alignment guide by 5 to 10 millimeters with a differential pitch drill. And you will always find a hypoplastic distal lateral condyle. You'll hardly have any section on the lateral side. Your distal femoral section in 3 degrees of valgus. You normally have a very tight patellofemoral ligament. So release the patellofemoral ligament. And as spoken before, your rotation of the femur is not with the posterior condylar axis, but with the transapicondylar axis and tibial cut. So you will have a parallax effect. The another marker to check on your tibial rotation is femoral rotation is you see a grand plantar sign on the top. Again, you have a very hypoplastic posterolateral condyle as compared to the posteromedial. When you go back, you realize that still you have a lot of laxity on the medial side. So you have to release the tightness on the lateral side. Once that is released, take off the osteophytes stenting the lateral collateral ligament. These osteophytes are taken off. You have to still go back in and see the rectangular flexion extension gaps. If you still have laxities, you will still have to release on the lateral side. So tightening of MCL is a very problematic situation. So releasing the lateral side is a way better answer across in these situations. And I normally do not like adding up the constraints, as majority of these knees are the CR knees only. Another problem is the tracking. Still you cite very tight lateral structures and your patella is subluxating laterally. So I prefer outside and release, saving the geniculars. Release the tight lateral structures and gradually we'll see your patella will start fitting into the femoral sulcus. On flexion, the patella is seating very well. You have full flexion achieved. Still one component is left, that is external rotation of the tibia because of the tight IT band. So IT band release is done. You identify the tight IT band structures, release the IT band, and now what you have to aim for is balanced flexion extension gaps, well seating patella into the femoral sulcus, and correction of tibial rotation by a release of the IT band. Once all these things are done, you have a well-aligned knee and the patient's walking the same day. So the basic parameter is in all these things, the soft tissue correction would give you majority of the deformity corrections. Dr. Baryard, we are messing up because he likes a lot of those lateral condylar osteotomies. I can keep it as a very strong backup. And similarly, what my dear friend Dhansekhar is going to show to you on the lateral approach, I use it only in cases where I have already dislocated or subluxated lateral patella. Otherwise, all these parameters are done by a medial parapatellar approach and almost in 99% of the cases with a CR knee. With this, any questions, I'll be more than happy to answer.
Thank you, Manoj. That's a very good detailed discussion. And we'll be discussing your subject during the discussion time. Dhana, are you able to come to get your slides?
Yeah, I'm there. Yeah.
Yeah, please start. Yeah, thank you so much.
Thank you, Dr. Rajiv. Good evening, Dr. Ram. Our two IAA past presidents, Rajiv and Subransu Mohanty, all the faculty. I'm going to talk about lateral approach to valgus knee. So indication now, almost all my valgus knee has started using this lateral approach because it's more convenient. And once you start doing a particular technique, you're able to do a better job with the one particular technique. So otherwise, generally, I use lateral approach. We have a surgical valgus more than 10 degrees that we will discuss. And patients with lateral subluxation or lateral mall tracking of the patella. So Ranawat classification we just now discussed. Type 1, type 2, and type 3. Type 1 is a correctable deformity. Type 2 is fixed deformities with attenuation of medial soft tissues. These are the knees which are amenable for lateral approach. And type 3 deformities, generally we, when the MCL is incompetent, we use a stranded medial approach with a hinge type of joint.
Dhansekhar, we are not able to listen to you. Neither the slides are moving.
Okay.
I'm able to listen him. Yeah, he's audible and visible also.
Yeah, his slides are moving and we can hear him.
We can hear you.
Yeah.
Yeah, okay.
We can hear you. Rajiv, there might be something with your net.
Okay, so I'll go ahead with this. So
Yeah, please.
what do we call a surgical valgus? Generally, if you do a valgus and varus stress, on a weight-bearing X-ray, there is a lot of valgus. But most of the time, the deformity is partially correctable. But if the deformity is more than 10 degrees.
Chandrasekhar, we are not able to listen to you.
Rajiv, actually, I am able to listen him.
Sir, he is
We are
very clearly
able to see
audible.
him.
I
Yeah.
guess something with your network.
I will go ahead. And this surgical valgus is what we need to surgically correct. The partial correctable deformity we need not address through a lateral approach. If the rigid deformity which need to be surgically addressed, then we prefer to use a lateral parapatellar arthrotomy. So this is an example where you have a valgus of 25 degrees on a weight bearing or a valgus chest X-ray, but it corrects to less than 10 degrees of surgical valgus. So this need not be opened through a lateral approach. So this is a video. So this is one more example. On the image on the left shows a fully correctable deformity. Right side is a rigid deformity. So the example of one more patient of a severe valgus. The valgus is partially correctable, but patient has more than 10 degrees of fixed valgus, which need to be surgically corrected. So in that cases, lateral approach helps you to directly address the tightened lateral structures, which are the IT band and the lateral capsule. So this patient, you can see the valgus only partially correctable. So 15 degrees of residual valgus is there. We need to correct at least 10 degrees so that your hip knee mechanical axis is neutral or a tibiofemoral angle is in 5-degree valgus. So the stress examination under anesthesia. So we use a midline skin incision. Expose the lateral retinaculum up to the tibial tubercle. So you open the lateral retinaculum. When you come to the level of the patella, you need to take the entire fat pad with the lateral flap. So you change your blade horizontal, lift the entire fat pad, you can see, which will help you to expand the tissues for closure. As we continue the exposure, the insertion of IT band into the Gerdy's tubercle will be released as a part of the exposure. Now we are releasing the IT band from the Gerdy's tubercle. We preserve the entire fat pad with the lateral flap for closure, because in valgus knee, the lateral retinaculum is contracted. So when you're closing, there's always a tight lateral closure. So once you do the exposure, we check how much of the deformity is corrected. Subluxing the patella medially is going to be difficult. Sometimes you might need to do a rectus snip so that you can dislocate the patella medially. So we use a valgus correction angle measured from the preoperative X-ray, do the standard distal femoral cut. And then doing the tibial cut is a bit tricky because you're approaching from the lateral side. Always mark the center of the tibial plateau, and then you use the extramedullary jig. You need to account for the extra-articular deformity also, which is present in some cases. So we do a minimal resection from the medial plateau. So now we check the extension gap. So laterally is just going in, medially it's opening up. So you can see the valgus stress, medially it's opening. Now you do the posterolateral capsule release, which is, we keep rotating the tibia internally and then expose the posterolateral corner. And then you check the gaps again. If you're happy with the gaps, then you go ahead and finish your further sizing and component rotation. But if it is tight, you measure the gap. If it's more than 5 millimeters difference between the medial and lateral side, it cannot be corrected with just soft tissue release, because the only tight structure laterally is the lateral collateral ligament and the popliteus. So now we mark the, now we measure that there is more than 5 millimeters difference between the medial and lateral gap. So now we're using the transepicondylar axis for rotation because the posterior condyle is hypoplastic. So always the condyles are internal rotated. You need to use more external rotation to get your tibial cut parallel to the femoral cut parallel to the tibial cut, or to restore the proper rotation. So I'm changing the rotation manually so that it will match the transepicondylar axis, and use this block and Ranawat block to check the gaps so that both the gaps are equal in flexion and extension. So it is 5 mm more on the medial side, both in flexion and extension. We complete the cuts, remove the posterior osteophytes, And I always use a PS knee. So it's a notch cut. Again, you can see medially the gap is more. The knee is opening up more medially, laterally is tight. So at this stage, we have released the IT band laterally and the posterolateral capsule completely. So only tight structure is lateral collateral ligament. So if you cannot lengthen the lateral collateral ligament, so I am opting for a lateral epicondylar osteotomy. So the distal part of the bone, which is beyond the attachment of the lateral collateral, will be removed and the fragment will be slided down. So that will lengthen the lateral collateral ligament with the popliteus attachment. We can also posteriorize if the flexion is tight. So now we allow the osteotomy fragment to slide down. So you can see how it slides down, and the distal portion, which is overhanging, has to be removed so that the osteotomy fragment will be fixed inside the femoral component. So you provisionally fix with a screw and then do the balancing. You mark the tibial rotation. It's very important when you're using a lateral approach, because your rotation, you might tend to external rotate the femoral component. So you need to keep the rotation correctly. This is how it is done. Then you can see how the joint is well balanced. Patella tracking is very good. For a type 3 laterally subluxed patella, automatically this approach forms a lateral retinacular release and helps in patella tracking. So you can easily close the muscle proximally, but once you come distally, the closure is going to be difficult. Here we use the fat pad to close the distal part of the arthrotomy, and it is very waterproof also. Then check the final tracking, the postoperative X-ray, alignment X-ray, comparing preoperative walking video to the postoperative walking. Patient is around 75 years, retired person, likes to cycle and walk. The deformity is completely corrected with the lateral approach. Thank you.
Thank you, Dhanshekar.
Thank you, Dr. Shall now, Dr. Rajiv, are you able to now?
Yes.
Yeah. Okay. So now I request Rajiv to share his screen. He will be talk.
Am I visible?
Yeah, visible, but not in sliding mode.
So you need to click on the first slide and go to slide share. Slideshow, sorry.
Can you see me now?
Sir, your slides are visible on a slide sorter view. You need to go on slideshow.
Not coming. Is it okay now? Are we able to see?
Yes.
We can see. Yes.
Very well.
Okay, thank you so much, Uttam. My apologies that today there has been a lot of issues in the communication. I think it is because we are beaming today's webinar through Facebook, YouTube of the IAA, as well as through the Ortho TV and IOA TV. So my apologies. I'm sure that next time it will be better. So I'll be speaking with them on the severe deformities, how we can work it up by the bony procedures, how to handle the extra-articular deformities, which are not uncommon in these situations, or the constrained implants, where you should use the constrained implants. So understanding the valgus knee is very important, and steps for correction, as we have seen in the talks of Manoj and Dr. Dhanshekar Raja. We have already discussed about the types of the genu-valgum by Abhay. I'll not go through it. The main issues that I'll be discussing are the components of the deformity. Intra-articular, it could be because of the wear of the cartilage and collateral frame retractions and stretching of the convex side. Or the deformity is extra-articular, which could be the femur valgum or could be the tibia valgum. That is what is to be seen. And that's how one of the very important thing is the lateral view of the knee. When you see the hypoplastic femoral condyles, you'll see that both the condyles will superimpose on each other and they'll be looking of the same size. That means that lateral condyle is actually hypoplastic, which is not an uncommon situation in these cases. The wear that is there, the answer is posterolateral soft tissue release that you saw in the videos and explanations of Dhanshekar, plus the unconstrained knee implant, as seen in the previous talks. If there is a contracture of the concave tissues, lateral, posterolateral, or posterior structures, the retraction is due to the inflammatory process adjacent to the worn joint surfaces. The plus patient may have a fixed valgus or fixed flexion deformities and the external rotation deformities. Answer is extensive posterolateral soft tissue release, but also you have to be ready with the semi-constrained implant, which is a very important thing. Or you may opt for adequate lateral soft tissue release, lateral epicondylar osteotomy that you just saw, plus the semi-constrained implants. If you have an elongation of the convex soft tissues, mostly occurring with the flexion deformity, it may be with the ACL rupture or the stretched MCL. The answer is very clearly extensive release and fully constrained knee implant like a rotating hinge, because these are the cases which may be totally unstable on the medial side because of the absence or the overstretched medial collateral ligament. And lastly comes the extra-articular deformities, which have to be corrected as with the intra-articular correction and constrained implant, or you can have the metaphyseal osteotomy or the diaphyseal osteotomy, as the case may be. Now, posterolateral soft tissue release, posterolateral corner, you have already seen that how these structures are released, or they need to be released. The iliotibial band, Manoj has explained very well that the iliotibial band has to be released, which is a very, very important thing in these cases. Which approach to be taken? Usually people take anteromedial approach, lateral approach only in the cases where you have a fixed genovalgum or you have to do a tibial tubercle osteotomy. These are the cases in my cases which are important to be taken up with the lateral approach. If the LCL release is done, preserve the popliteus. That is a very important thing. The release of the popliteofibular ligament, if you have to release, do not release the popliteus, but the popliteofibular ligament, if you can identify and release it, it helps a lot. Total meniscectomy for the vision, free the popliteofibular ligament, laminar spreader in extension, and palpate underneath the popliteus tendon. Then you will be able to see that. That is the direct lateral release, posterolateral release that you can do with a very easy way. But remember that the artery is very close, about a centimeter away. One has to be very careful and be careful that not to over-release the lateral collateral ligament, because it may create instability in flexion, especially if you exercise the posterocruciate ligament. And it requires definitely a constrained knee implant. Some cases, as you see that this patient is having a fixed genovalgum of both the sides, operated long back in 2006. We used probably the PS, the PF. This probably was the RPF joint with the use of the navigation. You can see that the correction is good just by the posterolateral soft tissue release. You see that how much of the ecchymosis is there. That means there has been a lot of soft tissue release in this case. And that's what you see the function and this patient's function at a follow-up of 2 years. Where you have a contracture of the concave soft tissues, lateral, posterolateral, or posterior structures. As we discussed, the answer is extensive posterolateral soft tissue release and semi-constrained knee implant, or with a lateral epicondylar osteotomy. The example is this patient with a proximal tibial fracture. The patella is subluxating laterally. It's a very bad stiff knee, significant valgus. Now, in this kind of a case, probably it is very wise to be prepared with a constrained knee implant, as in this case, and then you will have a good function in this patient. Other patient having the very severe valgus deformity, again a fixed valgus, that's what we see here. You see the better to choose a fixed bearing joint than a mobile bearing joint, because that will be a far more better approach. Metaphyseal osteotomy appropriate in younger patients to bring the femur and tibia in neutral. For example, this patient who has a significant valgus, and valgus is mostly in the femur. And we see that the lateral epicondylar osteotomy is done, and the lateral epicondyle is pushed distally, as Dhansekhar has explained, and then fixed with the screws. Initially, you may fix it up with the K-wires. Corrective osteotomy, where and when at the site of malunion, is the ideal thing. See this patient having the significant valgus, what we see. Ensure that you have first you have a distal cut, a femoral cut, tibial cut, and then see that you are not able to correct it well, then go for a lateral epicondylar osteotomy. When you do a lateral epicondylar osteotomy, make sure that this is at least 1.5 centimeter thick, so that it is a fixed, it's a strong chunk of the bone, and then shift it distally as is seen here in this, and remove the distal part of the lateral epicondyle. Hold it with a hook, maybe fix it with the K-wires, and then after you can use the fixation with the screws. And that's what you see this patient having a good function. The tibial osteotomy, this is the hyper-corrected high tibial osteotomy. What you see here, this patient is having the significant valgus, and in this patient, if we see that if we go for the normal tibial and femoral cuts, what you will end up is having a large amount of gap medially, so which will be very, very unstable joint. So in this kind of case, either you choose for epicondylar osteotomy or you choose for the tibial osteotomy, which is a better method. You cut the tibia, whether with the navigation or with the instruments, and then after, my trick is that I make sure that the femur is cut parallel to the tibial cut. Rather, the tibia is cut parallel to the AP cut of the femur. And then after, when you have made all the cuts, you can have a fixation, you can assess that what is the level of the osteotomy, and in that time you do the osteotomy, keep it incomplete, ensure that the periosteum is intact on the other side. You can hold it with the help of a staple temporarily, and then you may use the normal PFC sigma kind of implant, and you will normally have a very good result. That's what you see here in this patient. Important pointers are, look at the opposite leg, which will tell you what is the best alignment. And also, always remember that under and over-corrected genovalgum have to be avoided. Slight under-correction will reduce the need for the release, often limited to the arcuate ligament, and better stability and better function. And lastly, I'll request all the listeners, viewers, to become the members of the Indian Arthroplasty Association and join us for a better education. Thank you so much.
Thank you, Dr. Rajiv, for such a wonderful presentation. So now I think discussion.
Yes, I think that we have a 10-minute discussion on this subject, and then we take up the cases one by one. And the first case will be of Dr. Rajiv Verma. I'll request him to be ready with his slides. Dhansekhar, you showed a wonderful case of the epicondylar osteotomy. Are you there, Dhansekhar?
Yes, sir.
Yeah, okay. Right. So would you like to fix it up? The one thing that I want to make clear for younger colleagues is that would you like to temporarily fix it up with the K-wires, or would you like to fix it up with the screw fixation right at the time of the trial implantation? What I mean to ask you is that would you finally fix the epicondyle after the final implantation or at the time of the trial implantation?
I will temporarily fix it with the screws or a K-wire, whichever is practical, because the bone, if it is very strong sclerosed, then you can put a screw. If osteoporotic, we can put a couple of K wires and then decide where you are going to finally fix the fragment so that you can have an idea about your final insert and everything. Temporarily fix it, then you do a final fixation after you cement it. So a final fixation is done after cementing, and then you choose your final insert size.
That is a very good take-home point, that the final fixation of the epicondylar or the osteotomized segment should be done after the cementing the final implant, so that you can fine-tune the stability of the knee. Thank you so much, Dhana. Yes, Uttam, please.
Yeah. Can I ask one question to Dr. Dhanshekar?
Yes, sir. Yes, sir.
When you deciding a osteotomy, so what is your take regarding if you are doing osteotomy of lateral condyle, or if you are doing osteotomy of the femoral epicondyle and then advancing it? What is your take for advancing approximation of the medial medial epicondyle and then put in a smaller spacer, or we are doing the lateral epicondyle osteotomy and put in a bigger spacer?
Yes, definitely. Proximalization of the medial epicondyle is also a described technique.
Yeah.
I personally seen 2 failures, so I have not attempted that. But there is a surgeon from neighboring state who has done more than 30 cases of proximal advancement on the medial side. So definitely it can be done. But I have seen failures because always the knee is in loading in valgus, and this fragment is in distraction. So the bone quality is good. Definitely we can proximalize and fix it.
Dr.
Manoj, what is your opinion on this?
Yeah.
About the medial epicondylar osteotomy and tightening medial structures?
So I think my decision would be very, very clear, and a message across to all youngsters. If you have to do an osteotomy, prefer a downsliding lateral condylar osteotomy and just refrain yourself from a medial upsliding osteotomy. It looks simple, but medial upsliding osteotomy is a very, very tough part. MCL is the only structure you have on the medial side. If at all you do something wrong, the only choice will be a hinge. So if you have to correct on, rather than shortening or imbricating this MCL, work only on the lateral side.
Manoj, I think you have explained very well that the medial collateral ligament is a far more bigger risk to deal with in the middle epicondylar osteotomy. As much as possible, one should restrain himself to the lateral epicondylar osteotomy. And also, one more point I like to mention here, then I'll go to Mrinal for his opinion, that should you do, Dhana, the epicondylar osteotomy before the release, the lateral release, or would you decide after the release is done and you are not having the adequate opening up on the lateral structures, then you will decide the lateral epicondylar osteotomy?
So the osteotomy is done only after the release of the IT band and the capsule. So if you're not able to correct it, then I choose the osteotomy. Second thing, I look to answer Dr. Uttam's previous question. So we had 2 cases. One was medial proximalization technique was done. It failed. It has to be revised. Second case, it was a very well fixed implant, and the surgeon from UK did the live surgery in Ganga operative course. He did a medial reconstruction of the MCL with the semitendinosis. That also failed. So medial soft tissue reconstruction is not easy. Then again, proximalization also does not work. So lateral sliding osteotomy is okay, but this also cannot be done beyond the few millimeters of lateralization, because your deciding factor is the distance between the lateral collateral ligament attachment and the distal part of the femoral implant. So if you have to slide more than this, then you have to go for a hinge. So when you're using a hinge, automatically you are reducing the extension gap. You are doing a reduction osteotomy. You're not abnormally lengthening the lateral side so that your common peroneal nerve palsy does not happen. So within the limits of soft tissue release and a sliding osteotomy, there can be a good balancing done without the risk of common peroneal nerve palsy. If it's extensive deformity, better to straight away go for a hinge with intra-articular shortening so that you don't lengthen and cause common peroneal nerve palsy.
That's an important point, that if you have a, yes, Abhay, if you have a MCL, an inefficient MCL, then instead of trying only the osteotomy, you have to be ready with the hinge implant. I think that's a very important point. Abhay, would you like to say something on this?
Yeah, so I think a very important take home to understand here is that the purpose of the lateral epicondylar osteotomy will not be to perfectly give you a correction of the trapezoidal extension space. So it is basically to balance where your knee is already looking balanced, but still the medial side is opening more than the lateral side. And there is where you've done all the releases and you just need to distalize the lateral epicondylar, the LCL and you do a lateral epicondylar osteotomy and you balance the whole thing. But if you still have a trapezoidal space, that lateral epicondylar osteotomy is not going to do any correction for you there. So you need to balance your knee in extension, and after getting your balanced knee, if you still have an imbalance of the medial and lateral space, or you're not getting isometricity of the two collateral ligaments, that's when you probably decide to do the lateral epicondylar osteotomy.
Very right. The take home is that if you have a MCL deficient knee, then there is no point of trying all these osteotomies or too much of soft tissue release. Plan for the constrained implant, rotating hinge kind of a implant. Mrinal, you have any final comments?
So I think my question was already asked by you, whether to do lateral epicondylar osteotomy initially or do the releases and then do it, So I would ask a different question from Dhanashekhara, which would be like, what degree of flexion would he like to fix his osteotomy so that there is no flexion extension mismatch? So you can answer that.
So
that's a very important subject here.
So we'll do osteotomy, put your trial spacer, and then take the knee to a range of movements. It will allow the osteotomy to slide down. So when it slides down, we mark it in extension. What is the position in extension? Again, we take it in flexion and see where is the fragment sitting. So you can decide where you want to place it. If there is only extension tightness, you slide it down distally. If there is extension and flexion tightness, we slide it distally and posteriorly. In flexion, you see where the fragment is sitting and position that in that same place and then fixed with the screw in flexion. Very difficult to fix with the screw in extension. So you always fix it in flexion, temporary screw, and make sure it corresponds to the position where it was in extension. So you have an imaginary position, both in extension and flexion. You try to reproduce that, but fixation is in flexion only.
So have you ever seen any mid-flexion instability in such, once you've balanced it with the temporary positioning? Because once you're doing it in flexion extension, that point moves.
Yes. So, but most of the time we leave it a little bit tight. If you are lengthening too much, then you are going to have a mid-flexion instability. But when you're using an osteotomy, always slightly undercorrect so that the fragment is fixed tight and your lateral collateral ligament is always tight, both in flexion and extension. So that way you don't develop a mid-flexion instability.
So should you,
Mrinal, if you are able to sort of temporarily fix it and then fine-tune the fixation where you are going to fix after the implantation, the final cementing of the implant, then it becomes probably a very easy thing to manage the extension gap, flexion gap, and also the mid-flexion gap. Rajiv, you have some question? Yes, or comment? Yeah.
No, I just wanted to ask a question because
Manoj, we'll come to you after Rajiv. Yeah.
Dr. Abhay has shown that there is a case with a severe valgus and flexion deformity. So I just want a tip how to prevent, because CP and palsy would be more common in such cases, in fixed flexion and valgus deformity. So how, any tips and tricks to prevent those? Because I have not done those complex cases.
So, Dhanashekhara or Manoj.
Or Dr. Abhay.
Like to take up, yeah. Or Abhay, yes.
So flexion deformity is basically you require a posterior clearance. Normally you have osteophytes stenting the PCL. Once you do that posterior clearance, the majority of these FFTs do resolve. Only in a very complex valgoid with flexion, there you have fear on these cases of a CP and palsy. So there are the cases where you would leave your knee in a bit amount of a flexion on pillows and gradually keep stretching over time. But that's only in very severe cases. Normally for majority, the moment you sort of do a posterior clearance on the lateral side, that will get rid of your flexion deformities.
Okay.
In my experience, Manoj, that if we avoid stretching the deformity against the deformity, probably that is the best precaution that you can take to avoid the common peroneal nerve palsy.
Yeah.
Because the stretching injury is the worst injury. Dhanshekar, you have any comment on this?
So, mild flexion deformity can be corrected the way Dr. Manoj has explained. Do a posterior capsule release, it will automatically get corrected. And severe flexion with severe valgus, we have started doing common peroneal nerve release through a lateral posterolateral incision. We have done 4 cases like that, and we are able to release the nerve and reduce the tension. That avoids the common peroneal nerve palsy.
Okay. So one quick take is that once you've done your posterolateral capsule, that's what's going to be the posterolateral corner that's going to be tight. So once you've done the posterolateral capsule and the posterior capsule, the next step is probably the IT band. And if after that it is still tight, then probably it just opens up the door to either do a clearance of the common peroneal nerve at the head of the fibula, or sometimes even you can resect the head of the fibula and avoid. But as Dr. Rajiv said, that if you have to stretch to maintain correction, it's better to leave them in slight flexion and stretch them over time.
Right. Vijay, are you there? Pankaj?
So Rajesh,
If you have any comments, Pankaj or Vijay, and then after Manoj. Yes, Manoj, I think they are just joining. Yeah, please.
So Rajiv, why this question goes back to Dhanashekhar and you, specifically on your experience back to, when we talk about a complex varus knee, so today the talk is let's go in for a kinematic alignment, leaving the knee in 3 degrees of varus rather than doing an osteotomy. Now, vice versa, Dhanashekhar, that you have a knee which is trapezoidal, you have 2 choices to move through. One is doing a lateral epicondylar osteotomy, and second is putting your femur in some amount of an internal rotation where you can still cheat around to balance your patellofemoral dynamics. In which case you would prefer a few degrees of internal rotation, and where you would prefer an osteotomy?
So if it's a slight valgus, less than 10 degree of surgical valgus, I'll do these 2 described techniques. You can slightly put the tibia in valgus or the femur in slight rotation. So surgical valgus less than 10 degrees, which can be corrected only by soft tissue release or with some bony correction. So these are the indications for a slightly under correction on changing the component rotation. So when the surgical valgus is less than 10 degrees, I always do this technique. I routinely practice what you are describing. So well-described technique to avoid unnecessary soft tissue release, and minimal change in component does not affect long-term outcome.
I think I would have
very right. Very right. Manoj, what I prefer is that if you leave some amount of valgus deformity up to 3 to 4 degrees, I think it is better to leave in some amount of valgus, because this patient has been in this significant valgus deformity for many years. That is one thing. And also leaving at 3 to 4 degrees of valgus will also reduce the amount of the release, as Dhanshekar has just explained. And I think that is a very, very right way.
Rajiv, in our practice, when we find
please don't leave this obese patients, especially short Indian females who have got obese thighs in valgus, because they will not be happy to have a valgoid knee after the surgery, because the thighs will rub against each other while walking. So that is why in short obese females, it is preferable that you achieve a good correction or live neutral rather than leaving a valgus in short Indian females.
Right, Shubhranshu. And also one last thing, that many of these patients may have the recurvatum along with. So one has to be careful and ensure that you observe it very well on the table. If there is a recurvatum deformity, ensure that this is corrected well, because leaving the valgus and recurvatum both will be very bad, and especially in an obese patient. I think very right. Yes.
Manoj, what
usually rheumatoids are flexion deformity with valgus, and osteoarthritis are recurvatum with valgus deformity.
I think very right. And I think any last comment from the faculty, and then we'll move on to the case presentation.
No, Dr. Rajiv, we'll ask Manoj his opinion. He raised the question. What is
please, Manoj. Yeah.
In my cases, whenever I find that the patient is osteoporotic and I have huge chances of failure of my fixation, those are the cases in which I would prefer to go in for a bit of an internal rotation and not take a risk of losing my osteotomy fixation. In all other cases where I have a good bone stock, decent bone stock, and I know that my osteotomy is going to hold well with screws, that's the place where I prefer a lateral condylar osteotomy.
And we have to be clear that under correction is like 2 or 3 degrees, not more than.
Not more than that. Of course.
I agree with this.
And Dr.
So with
Rajiv,
this, we close the discussion. Yeah, Dhanshekar, please.
you got an excellent case of extra-articular overcorrected valgus, well corrected with osteotomy. Congratulations on that. Very nicely done.
Yes, I think in these cases, it is better to accept and plan beforehand so that you are very sure that you are not doing the unnecessary releases and you are sure that you are going to do the osteotomy. Thank you so much, Dhanshekar and Manoj and Abhay. And we'll now go on to we'll close the discussion and we'll go on to the case presentation. And in the faculty, Dr. Sanjeev, he's there from Jammu, Mrinal, and our all faculty. Please participate. Dr. Rajiv, are you going to share your screen?
Yeah.
Please. Today we have a small issue with the IT, it seems.
I can't share it. I don't know. There is some problem.
I think we'll have to do a trial sharing of the screen with IOA TV and Ortho TV. maybe that is too much of soft tissue. Software glitches are there.
Can you see my screen? No.
No, we don't see at the moment.
Okay.
Nirmal, please be ready with for the next case.
Can present here.
Nirmal, if you are ready, can you please come? Okay, Mrinal, finally we'll have to request you.
Both are not here.
I'll sit with Dr. Ashok Shyam of Ortho TV and try to sort it out for the next time. We can see screen, Mrinal.
Make it full screen, Mrinal.
Go to the slideshow, right? Yes, we can see it now.
Okay, fine. So I'll be presenting a case which would be probably a cakewalk for stalwarts, but a learning message for youngsters. This is a 66-year female, actually. She came to me in 2016 with bilateral knee pain, and she was rheumatoid, and she had this wind-swept deformity. And I advised her total knee replacement, which she did not agree to. And almost 6 years down the line, she came to me. It's not moving.
Yes, okay, now.
So this is how she came to me. Suddenly, the attendant said that she stopped walking, and she came on a wheelchair to me, and this is what she had. So you can see that she's developed a stress fracture in the upper 1/3 of the tibia, junction of upper 1/3 and lower 2/3. You can see the skin condition also. This is how she was when she came. She had previous surgeries during the childhood. We don't know the detail. There is some bone formation also between the tibia and fibula. And there is a scar mark, puckered scar mark, which is actually adherent to the bone. So obviously this was a little tough situation for me because I could not assess. Rather, my resident who evaluated her also got the stress views done, thinking that probably this was a very lax knee, and that's why we have those varus valgus views here. So the plan was how to expose, because there was previous surgical marks, what cuts to be taken, what are the releases I would need, and what kind of implant would be needed, because I also have a fracture down there.
And okay, so before you go ahead, Mrinal, can we go back?
Yeah.
Can we go back to the, yes. That's right. So in this, in the presence of the lateral surgical scar, previous surgical scar, can we ask the faculty that what is the approach that they will prefer? Manoj, would you still take up the medial parapatellar approach in this case, or you'll prefer a lateral approach?
I think he has left.
Dhanshekar, what would be your preference? Shubhranshu?
Yeah, I will see whether the scar is matured or not. If you can pinch the skin and lift the skin away from the subcutaneous tissues, that means the scar is matured and unlikely that you will develop skin problems. But if the scar is not matured, then we can go for a through the same approach. But if the matured scar, I'll still prefer a anterior midline incision.
That's a very
medial
important
parapet.
take-home message, Shubhranshu, that you have given, is that if the scar is adhered, then it is better not to touch it, right? If you have to go for the medial, yeah, Vijay, good that you are there.
So one of the main, here I think you should also have an opinion of it. And I think I would go by the lateral most. By the lateral, I normally do a medial parapatellar, but here the scar looks quite lateral. And I think it would be difficult to go from the medial side. So, there's a chance of skin necrosis. So I would maybe err on the side of a lateral sided scar, lateral sided incision with a lateral parapatellar approach in this case.
That brings us to a very interesting point, Vijay, that when you take a lateral approach in this case, would you just take the lateral approach soft tissue procedure, or would you also add it with the tibial tubercle osteotomy? Because I believe that this patient is having a stiff knee as well.
If the exposure is difficult, then I would have a very low threshold to do a TTO.
Right. And for the younger colleagues, if you go for the medial parapatellar incision, then you will ensure that the incision have the two incisions, the previous one and the one that you are going to make. You should have at least 4 to 5 finger distance between the two incisions, so that the wound healing is not a problem. We go ahead, Mrinal. Yeah.
So you raised a very valid point, Dr. Rajiv. This patient also has a patella baha, and actually a tibial tubercle osteotomy would do wonders in this case, because you will be able to also, bring the patella up. So this is what I did, and you can see there is a hypertrophied medial side of the quadriceps, the muscle, and the tendon is skewed up, you see. So I followed the lateral most incision and got it down towards the medial side, just above that scar. So the hypertrophied VMO, or the medial quadriceps, was actually excised, means the joint was opened through that skewed scar. And then I went inside, and this is, you see, the high kind of osteophytes which were there, which were actually, I couldn't find them on the X-rays itself. But they were pretty hypertrophied, and there is obviously a defect in the tibia, you can see, and there is the hypoplastic lateral femoral condyle, the typical things which we see in a valgus knee, apart from a patella baha. So there were a lot of, I could understand there could be skin problems, there could be bony defects, there could be a need of a long stem. So all these were planned. And I went in, I did a 3-degree valgus cut, did the distal femur first, and hardly any bone was cut from the lateral femoral condyle, as is usually seen. Now I had asked.
So here, Mrinal, before you go ahead, can I ask the faculty that how many of you take the 3-degree valgus instead of 5-degree in all the valgus knees? Shubhranshu?
I always take 3-degree valgus cut in a valgus knee.
Yeah, and Nirmal, what is your take in these cases?
I always pick a 3-degree.
3 degrees. Vijay, you also any different?
Always 3 degree, but I would do my tibia first. No, I will not do the femur first. Yeah.
And also related question: where will be your entry point? Will it be the same as we normally make, or would you medialize or lateralize this entry point?
Yeah. So normally you have a scanogram, and it is quite medial to where you normally do for a, because the straight line is quite medial to the normal.
Shubhranshu, you agree?
Yeah. Normally I plan my X-rays beforehand. So I put the axis, draw the anatomical axis of the femur, and wherever it comes out, usually in valgus knee, the distal femur is little valgus, and hence the entry point is little medial, couple of millimeters medial to the
very right. Pankaj, are you there? Pankaj Valecha?
Yes,
if we go ahead, man. Yeah, you're there. Okay. Pankaj, do you take anything different in these cases where you have a valgus knee and you will take up the normal 5-degree valgus and the entry point as we normally make, or you will change the position of the two?
No, sir, I fully agree with the comments already made. medial entry and 3 degree of rotation, yes.
Very right. Very right. Mrinal, please go ahead. It's a very interesting case.
So I had asked for intramedullary cutting jig for the tibia, which was not sent. So the only option I was left with is either to open it up and put in a small plate and reduce the fracture, and then go with my tibial cutting jig, extra medullary jig. The other option which I devised on table was that I used a distal femoral entry drill which we have for the tibia, and I put in the extra medullary rod through that into the tibial shaft. So that reduced my fracture. And then I could put in an extra medullary jig, and after that I removed that jig and I could do my proximal tibial cut. So this was an innovation which I made on table because I did not want to put in a plate and reduce the fracture, especially when it was an acute fracture, it would have easily reduced. And I checked during the on table with the C-arm that I am reaming in the correct direction. And I plan to put in a snug fitting tibial stem. And I did all the lateral releases as have been proposed in the previous, by the speakers. And ultimately it was so stiff in the valgus that I even had to release the popliteus. So,
Mrinal, here I'll just make one small comment here. If you go back to the earlier slide.
Yeah.
When you make a tibial cut, and tibial cut is always a problem in these cases where you already have a deformity, extra-articular deformity or a fracture. So one easy method could be that you make the femur first in these cases instead of tibia first, and then keep the tibial cut parallel to the AP cut of the femur. If that is possible, it will save you a lot of issues of initially fixing it up with the rod as you have done.
Yeah,
it's a very good method you have shown.
I have actually done the distal femur cut first, but I could hardly cut anything from the lateral femoral condyle. So I couldn't have that judgment on table, and moreover, the fracture was acute, so it was very mobile. So I thought better to stabilize it and then go ahead with this. And it did the job for me. And this is the final alignment I could get on table in flexion and extension, you can see. And these were the final X-rays immediate post-op and almost 3-4 months post-op. And this is the scar. Which
so you just mentioned that you had to release the popliteus as well.
Yes.
Yeah, that is a interesting point. Shubhranshu, what is your opinion about the release of the popliteus?
I would rather, don't touch the popliteus in a valgus knee. Because valgus, that is the only stabilizer on the lateral
because
side.
It is a stabilizer, right?
Yeah,
right. That's a very good point.
The posterolateral capsule, IT band, etc. But popliteus, I don't touch in a valgus knee.
Vijay, what is your opinion? Pankaj?
So generally, I would avoid.
I also don't want usually,
Vijay, your voice is breaking.
Yes.
Pankaj, you were saying something?
Yes, I was saying I would generally avoid touching popliteus and lateral ligament unless there is nothing else left for me. So that's my usual approach. But yeah, case-to-case basis, I mean, I don't know what Dr. Mrinal felt during the surgery. If he felt that there's nothing else which can be done except releasing popliteus, is it so?
Yeah, because this was a very deformed case, Mrinal, I believe. And in this extreme situations, I think release is okay.
So in this first picture, you can see that the medial side, lateral side is very tight. Even after all the releases I've done, the only option with me was to either do a sliding epicondyle osteotomy, or go ahead and try and do the release the popliteus first, and then try and balance it. Release of
what was the final?
So the release of popliteus itself opens the joint up to 8 to 10 millimeters. Once it's very tight, then this is the option which is left, or you can go ahead with the sliding condyle osteotomy, which will bring obviously the popliteus down also.
Right.
So this
is Mrinal, at this fracture site, did you use the bone graft also, because you had the ready bone graft with you?
No, I did not open the fracture site. It was a very acute fracture. Just 2 days ago that fracture had developed.
Right.
And you can see it is already healing well. I put it her on teriparatide. She was rheumatoid. She was osteoporotic. That's why she sustained this stress fracture. And she was walking on it just before 2 days before.
Right. And just for the younger colleagues, that when you put this, a very well fixed thick stem, but be careful that these kind of patients can have another fracture in the post-operative phase. So one has to be careful for that. Thank you so much, Mrinal.
Sir, key learning points are there for the youngsters. So osteoporosis needs to be taken care of. These severe deformities have stress fractures. We can use intramedullary tibial cutting jigs and temporarily fix the fracture with a small plate. And you can use stem extenders to bypass the defect, and fluted stems with a hybrid fixation should be used. There's a beautiful classification given by Dr. Mullaji, published in 2010, which tells you how to deal with acute, united, and malunited stress fractures with intra-articular or extra-articular deformities. And there is a beautiful chapter written by Dhansekhara in my book on knee arthroplasty, which deals with total knee arthroplasty with stress fractures. So youngsters should read that chapter. Thank you.
Thank you so much, Mrinal. I think it's a very good learning case for all of us. Nirmal, are you ready with your case now? Can you please share your screen? Then I'll request Rajiv to be ready.
I was just one question to Dr. Mrinal.
Can I try sharing?
Dr. Mrinal,
please do it. Yeah.
Continue.
Yes, Dr. Uttam.
In the meantime, Mrinal, you can answer the question of Uttam.
Yes, Dr.
In this case, you have just already released this popliteus tendon. So which implant you have chosen? You semi-constrained or unconstrained or something like PS or PFCR, whatever.
I could after release, I could balance the knee. So I did not need to use any constraint. I used simple PFC sigma with the stem extension. That's it. And it was totally balanced. You can see on table.
All right. The other issue is that all these cases which are the stiff knees, they are not so unstable when you are releasing the soft tissues. So that scarring itself provides probably some kind of a stability.
Yes.
And Neeraj, are you sharing your screen, please?
Another thing that if you're not opening the fracture site,
Okay.
yeah, if you're not opening the fracture site, the reamings itself, provides the graft there at the fracture site. When you ream it, the reamed cancellous bone, they reach the site, and because you have not opened the fracture site, so that provides, additionally bone grafts to the
Very
fracture
right.
site.
And now Dr. Nirmal Jajodia from Durgapur will be presenting his case of lateral epicondylar osteotomy. Nirmal, please.
Yeah, thank you, sir. Is everybody able to see and hear me?
Yes, sir, we can.
Yeah, we can.
So I'm presenting a case of a 54-year-old lady who presented with bilateral knee pain and deformity. The right knee was more painful and deformed. There was a valgus deformity of 30 degrees and it was not correctable at all with the right knee with a laxity of the MCL. It was a grade 2 deformity by the classification that we go because there was no tibial osteotomy or tibial defect. The range of motion was a 5-degree hyperextension to 110 degrees of flexion. Now, we know the classification, we've gone through that, so won't to be delving more into that. Now, this was the preoperative X-ray of the patient, where we have about 25 to 30 degrees of valgus, and this is a stiff valgus. There is no correction on varus stress. And as you can see on the lateral X-ray also, that there is a lot of hypoplasia of the lateral condyle. So just to refresh the structures which are tight in extension, we know that the IT band and the posterolateral corner of the capsule, when it is tight in flexion, it is the contribution from the popliteus. And when it's tight both in flexion and extension, we have the lateral collateral, and epicondylar osteotomy is one of the procedures of choice. However, there is a high rate of instability in the paper by Ranawat, where they say 24% instability if you choose this as a procedure of the release of the lateral collateral ligament rather than the epicondylar osteotomy. So the bony release of the epicondylar osteotomy becomes the procedure of choice if you have a knee which is tight both in flexion and extension. Now, to make you understand what happens when we do a epicondylar osteotomy, is an interesting chapter in the book of the arthroplasty. That is the axis of rotation of the tibia on the femoral condyles in a valgus knee. Now, in a situation where the tibia is not deformed, the first distal femoral cut where the femoral is placed, which is perpendicular to the mechanical axis, distalizes the axis of rotation in extension, but doesn't do anything for the axis of rotation in flexion. Hence, you will always have a situation where you would require to balance the collateral ligaments, do something like an epicondylar osteotomy, which distalizes the axis both in the range of flexion and extension, like we were discussing in about, that isometric point of fixation. So this procedure is helpful when you have a severe deformity in the distal femur and no deformity in the tibia. However, be aware if you choose this procedure for the type C types, the type 3 of Krakos, because when you choose this procedure for the type 3, where there is a tibial deformity, what you are doing is you are distalizing and then you're altering the rotation axis in flexion and in extension. So instead of choosing an epicondylar osteotomy to balance the type 3 deformities, you should be choosing probably a corrective osteotomy, as was shown in one of the previous cases by Dr. Rajiv Sharma. Now, we chose to have in mind that we might require an epicondylar osteotomy of this case because it was a rigid valgus. And how is it done? You get a 3 or 4 millimeter, 5 millimeter slide. You do a distal femoral. After your distal femoral and your cuts, your fine finishing cuts are cut there, and you maintain a part of the anterior femur, and you do a transverse cut, and then osteotomize. Use your osteotomy to complete and leave the periosteum attached to the epicondyle, to the fragment. After you've done that and you've distalized, you fix it, and then you shave off the extra bone that might be coming into the way. Now, this is the video of the procedure that this patient required. We did a iliotibial band and a posterolateral corner release in extension, but the knee was still not balanced. At this point, we wanted to assess what is the residual component of deformity by the collateral ligament and the popliteus. And when we did the component internal rotation and we chose the gap balancing method, we were still having a lot amount of tightness. Hence we decided that the structure which was contributing was the collateral and the collateral and the popliteus, because there was a tightness both in flexion and in extension. And at that stage in the surgery, we decided to go out with a epicondylar osteotomy. So we have marked the medial most margin of the osteotomy. We won't go medial to that because we'll end up into the shaft with KOS, and then that is the osteotomy being done. So after you've done the distal cut, you take an osteotome, flip it open. It's like a green stick fracture that you create, and then you take some soft tissue and periosteal sleeve left with it. So complete the cut and then flip it back. So still remains slightly attached so that it slides along with the tissue sleeve. And once you have done that, the biggest challenge is to find out what is the isometric point of fixation of this fragment. So after you've done that, you implant your trial components, and then you give your shortest insert, which the medial side is accepting. And that will gradually stretch the ligaments down, the fragment down, distally and posterior. Now here it has gone more posterior than distal. So as we put the trial spacer, it still doesn't go in easily. We have to do a bit of struggle and gradually releasing the periosteal attachment and letting it slide further and further posterior. And we would be able to get the insert in and a good balance at that stage. And that is your point of provisional fixation after you run the knee through a range of motion and find out the point where it lies the best. So after we have inserted with a, yes, that is where the insert starts going in, and you get a knee which is in completely balanced in flexion and extension and well aligned mechanically. And that is the point you decide the point of fixation of the lateral epicondyle. So this is the post-op X-ray where we can see that the fragment has slid slightly distally and more significantly posteriorly. The extra amount of bone has been trimmed, and we could still manage with a primary cruciate retaining knee without any constraint and a well-balanced knee with a good function. So that was the deformity, that is the balance. And that is the post-operative walking video at 3 months of the patient. The left knee is still due for another surgery, for a surgery. The right knee is completely balanced. There is no thrust and no instability on walking. Thank you, sir. That's the case. I'll be open for any questions, sir.
Thank you, Nirmal, for a very lucid case presentation. It was a very good learning point, especially about the epicondylar osteotomy. For beginners, I'll point out again here that in very osteoporotic bones, one must avoid doing the epicondylar osteotomy because the fragment will be very much shattered, will not be able to hold very well with the screws. And if it is done, Dr. Nirmal has shown very well that it can, once you do the osteotomy, it can decide itself how much posteriorly it has to shift or distally it has to shift. That was your message, Nirmal, I think. Yeah.
Right, sir.
Any comment, Pankaj or Vijay?
Excellent case, Dr. Rajiv. Yeah, excellent case, Dr. Rajiv. I think, the stiff valgus, especially the stiff valgus, you should know osteotomy. And as rightly pointed out, you should be careful in rheumatoid osteoporotic patients. Very careful if yeah.
Yes, and I agree that Nirmal, that you have decided beforehand that this patient will need a epicondylar osteotomy, and I think that is a very right approach. And instead of trying to release the lateral collateral ligament almost completely, and then after going to the epicondylar osteotomy. Mrinal, you have any point in this?
Sir, I think I totally agree with you. For the medial side, we can do the releases and then go for the medial condylar sliding osteotomy. But if there is a fixed valgus, you should initially, if you decide that you would need probably maybe valgus of 20-30 degrees, which is fixed, you will need a sliding condylar osteotomy. Go straight away with that. That is going to make your life pretty easy from the beginning.
Very right. Can I request Dr. Rajiv to sort of share your screen?
Yeah,
so that will you be able to show your case?
Yeah. Can you see?
Right. Yeah, put it on the slideshow, please.
Yeah.
There's a question in the chat box that what is your post-operative protocol? Do you change after doing a lateral epicondylar osteotomy?
Nirmal, would you like to answer?
Nirmal, what is? Yeah, Nirmal. What
so
is
there is no change in the protocol. The fragment, because the lateral side is usually sclerotic in the non-rheumatoid knees, and you get a good bony fixation, and none of the post-operative rehabilitation changes. We just go regularly standing full weight bearing and allowing the range of motion from the second post-operative day.
But Nirmal, in my cases where I do the epicondylar osteotomy, I give them the knee immobilizer for walking for a period of 3 weeks as a added precaution. I think it's a small precaution. It doesn't harm us in any way. And always the problem happens when the patient is walking in extension. Right, Dr. Rajiv Verma, please start your case.
Thank you, Dr. Sharma and Dr. Uttam Garg for letting me present a case. I think after all the difficult cases, I'll finish with a very simple case, because what Dr. Uttam asked me was to do if you do a lateral parapatellar approach, which obviously I was trained.
But a very important subject, I'm sure.
And I'll start with the case. So this is a 62-year-old, as we have seen until now. A lot of them have got windswept deformities. So the right knee is valgus, but obviously the middle compartment is also destroyed, and there are a lot of osteophytes. And the left knee is severe varus. As these patients come to us a bit late, so this is in the OR. I am checking for is it correctable? It is. You can see the varus, but the other side is correctable. The valgus is correctable. It's probably a grade 1. Grade 1, according to Ranawat's classification, this is a grade 1 valgus knee, which we see in almost 80% of the cases. So I normally use a lateral parapatellar approach, which I was trained while working in UK. And we had a lot of Asian patients in Bradford where our consultants used to do a lateral parapatellar approach. So I normally take around 3 to 4 finger breadths above the patella and up to the tibial tuberosity distally. But we can increase the incision as we like, or if the deformity is severe, we can increase it. So what the literature tells us, and what we have discussed now, once we do the lateral parapatellar approach, we actually deal with the deformities itself during our approach and the approach to the joint. So we make an incision releasing the lateral retinaculum, which can release a lot of deformity. And after that, if you see that I have already removed the osteophytes, which is an important part for any varus knee or a valgus knee, from the femoral condyle as well as tibial plateau. And then we I'm trying to release iliotibial band from the Gerdy's tubercle, which will take care of a lot of our valgus problem, definitely in 80% of our cases. And then we can release the capsule also, lateral and posterolateral capsule, to correct the deformity. So this is, I'm just showing that because once you have got a severe valgoid knee, then we have to keep the fat pad infrapatellar as well as on the lateral side, which helps in closure. In this case, it wasn't that difficult, but I have seen during my registrar years that sometimes we cannot close it without the help of the fat. So this is the intraoperative picture with hypoplastic lateral condyle of femur and eroded lateral tibial plateau. There's obviously a lot of erosion in the medial side also. So if you see these cuts, as we have already discussed, there will be very little cut on the lateral side. I also use a transepicondylar axis to check my rotation in these cases because of the hypoplastic lateral condyle. So I mark it with a cautery. This is the tibial cut. I took lateral 2 millimeter just to balance the knee. This is trial implantation. And I also, if you see it carefully, I have also marked the tibial rotation with my trial implantation, which has been told by Dr. Sharma and all our faculty. So this was the closure. Sometimes you find it really difficult if in a severe valgoid knee. So then at this stage, the fat helps. This I can see there's no patellar mal tracking, and I've got a good range of flexion and extension movement. So this is the post-op X-ray. I have used a posterior stabilized knee. So this was just the one case I could take the pictures intraoperatively. This I just did around 3-4 days back. These are the old cases which I have done, but I didn't have the intraoperative pictures. This is the right knee is also similarly severe valgoid knee. And obviously in this I have used a constrained implant. This was an international patient, obviously African patient came late. This is a similar case. So I think with a simple lateral parapatellar approach, we can get the correction in simple knees. That is 80% of the cases. So this is a video just to show that if we enter the correct space, if we take a correct approach and enter the correct space, we can actually see what we want to see and release what we want to release. Thank you.
Thank you so much, Rajiv. I think the last video showed the summary of this whole webinar, that you need to know exactly what is the answer for the problem that you are dealing with. If you don't know the right place where to do the release, there will be a major issue. Nirmal, you have a question to Dr. Rajiv?
Dr. Rajiv,
yes, sir.
There is a description for the expansion of the lateral arthrotomy by a horizontal Z plastic kind of a thing, the Kiblish modification of the lateral approach, so that the soft tissue closure becomes easier. Any experience with that?
No, I haven't not done this. I think it's a lateral arthrotomy and coronal plane Z plasty, you mean, isn't it?
Right.
Yes.
Yeah,
I have not
Yeah.
used it. Yes, I have not used it. No personal experience. But yeah, it's been described in the books, and it is, I think, described in 1991 by the person who described, I can't remember his name.
Dr. Kiblish, I think it's a
Yeah,
Kiblish
yeah,
approach.
It's a Keblish approach where you have to, it is for the very severe valgus deformity.
Severe valgus deformities, yes, sir.
Yeah, right.
Yeah.
The one thing that I'll point out here, Rajiv, that all
Yeah.
these cases where you take the lateral approach, one has to be ready that these patients may bleed more.
Yes.
Right. And in a stiff knee, probably the easy approach is you do it along with the tibial tubercle osteotomy.
Yes.
Another very important point in all these valgus knees is that you should be ready. Transepicondylar axis is a very important parameter. And if you should be ready to rotate your femur laterally more than normal in many of these cases.
Yes.
So one has to be very careful about it.
Yeah.
And we have learned very well about the epicondylar osteotomy by various examples given by all the previous speakers. Thank you so much, everyone. And if there is any last comment in this webinar, maybe Rajiv, you can stop sharing your screen.
Yeah, I'm just trying to. So this is my last.
Any last comment from the faculty, and then we'll be stopping the live streaming of this webinar.
Sir,
Pooja, are you? Yes, please. Uttam.
Anti, yeah. Are you there, Dr. Mahanti?
Yeah, Mohanty is there. Yes, yes.
So what is your take in the valgoid knee in the type 1 and type 2? Which approach should be preferred? It should be lateral parapatellar or should it be medial? What is your take for young generation? And in grade 1 and 2?
Grade 1 to it is always medial parapatellar. Always medial parapatellar. Even in grade 3 also, I take medial parapatellar approach. The lateral parapatellar approach is good to learn as an arthroplasty surgeon, but it has its own share of complications also. It is not that great that one has to practice, but most of the 99.9% of valgus knee, we can correct it through medial parapatellar approach.
Yeah, Uttam, in my opinion, the lateral approach is restricted to those patients where you have a very severe fixed valgus deformity, where you have a previous scar which is laterally placed, and you need to take up the same scar. I think these are the two very important indications. Mrinal, you have a comment on this?
Sir, I just want you to discuss your salient points for recommendation in a valgus with hyperextension.
The valgus in hyperextension is a very difficult deformity, and one must recognize your knee before you start the bony cuts. One of the very important thing is that you ensure that your femoral cut, the distal femoral cut is lesser. So you cut the less distal femur and ensure that you don't release posteriorly. And in these cases, if you have a slight suspicion, you have to have the constraint implant ready in your operation theater, and also with the extension stem. Because my feeling is that in the moment the patient is having an unstable knee, stabilizing it with increasing the constraint within the implant will also mean that there will be more stresses at the implant bone surface. So these patients should always be used with the extension stem, whether you use a primary knee implant or a revision knee implant. Abhay, you have a different opinion on this?
Sir, I feel the valgus hyperextensions are the ones which will not be tight. So they will always be correctable. The issue is to balance them. So I think the key things here is to minimize your cuts, both on the femur and the tibial side. That's absolutely primary. And once you get a balance, and then it is basically a take on whether you want to do. So even if you're using a primary implant, I would only go up to an extension stem if I feel that because of osteopenia, I want to protect my fixation or any other reason. But the valgus hyperextensions correct well. So maybe what we would like all the faculty to express their take home is, in cases of the valgus flexion ones, which are the rigid ones and the stiff ones. And those are the ones which even after your corrections, sometimes, they will have some corrections left behind. And then what do you do for them? And those are the ones which you probably have a higher risk for a CPN.
So I would like to add on something.
Right, Manoj.
Yeah. So if we have an hyperextension, probably the stem would be needed if there is an anteromedial defect and you need to build it up. Because usually you see anteromedial defect laterally in the tibia, where you might need some kind of augment or probably a tibial stem. And also in those which would have probably a neuromuscular element where you might need a constrained implant or a hinge. So those are.
And also one very important thing, Mrinal, that you must always give the knee immobilizer in about 10-degree flexion for a period of 3 to 4 weeks in these cases. Because the posterior capsule, Because
Sir,
the
please.
posterior capsule, if it is legs, then it's a major thing. And if you find that the posterior capsule is legs, which may happen in many of these cases, you should ensure that you use a constrained implant in these cases.
Sure.
Yes,
Sir,
Mrinal, you were saying something.
One thought process on these situations is that we need to look at them as revision, as we look at the revision scenario. So when you feel your zone 1 fixation is not going to be enough, you add fixation. And in today's times, we have good enough implants where the keel has a good length for us not to worry too much. So if you're adding a stem, then you're probably looking at an additional zone 2 fixation, and then you just need to do a hybrid cementation and just cement the proximal part so that you prevent proximal stress shielding as well.
You're right. Very important point. Mrinal, you
But
have any more
sometimes-
point before we close this webinar? Shubhranshu, yes, please.
But
Last
your last
question I would
comment.
like to ask.
Yeah, just before that, in corollary to Abhay's answer, whenever you are adding stem, you have to be careful about your base plate position. Sometimes your stem decides your position of your base plate. So if you are giving a good coverage without a stem, and you put the stem, there's a possibility of little overhanging here and there, depending upon the anatomy of the proximal tibia. So that is why, if at all you are using the stem, if there is a chances of alteration of position of the tibial base plate, better to use a short cement stem rather than a long stem uncemented one, where there will be diaphysial fixation.
Or in these cases, probably an offset stem could be an option.
Yeah.
Uttam, your last question, and then we close this webinar.
And to yourself, Dr.
Yeah,
Rajiv.
please.
In a valgus knee deformity about 20 to 25 degree in extra articular deformity, what is your opinion regarding correction? Will you like to prefer correctly the intra-articulary, or will we go for the supracondylar osteotomy?
The sequence is in these cases. First, the identification whether the deformity is in the femur, which is most likely, or the tibia. And when you are sure that you have a deformity in the femur, you do the release, and the release is not enough to control the deformity, to correct the valgus deformity. In these cases, go for the metaphyseal osteotomy. And metaphyseal osteotomy, supracondylar osteotomy, is a very easy method, unlike what we probably may fear about. Be careful in doing this osteotomy. Use the extension stem and keep the opposite part of the bone, periosteum, intact. So once you keep the opposite periosteum intact, the osteotomy remains significantly stable. And then using the stem and fixing the implantation is very easy. Yeah, and you can use the staple, 1 or 2 staples, to fix it temporarily on the table. And then after, you may leave the staples there, or you may just remove.
Dr. Mendel?
Yes.
What you will suggest? Any opinion?
I think what Dr. Rajiv is saying is perfectly fine. If you have an extra-articular deformity going by the Wang's principle, if it's not cutting onto the, if it's cutting into the condyles, then you do intra-articular correction, or you go for extra-articular. You can do it same stage, or you can do it in 2 stages. That depends upon your.
Right. Very right. Thank you so much, everyone. I think this was a very interesting discussion. Very interesting presentations of the talk also, as well as the very interesting cases. Excellent participation of the faculty. Thank you so much, everyone.